A very good morning, respected faculty members and delegates. I welcome you all to the 17th Renal Clinical Conference. The first Renal Clinical Conference was started in 2006 on the occasion of Professor Chako Korula Jacob Sir's superannuation and has since then been a great learning experience for all nephrology trainees. Today we have 8 bright and diligent nephrology trainees who are here to present cases on core nephrology topics, which will be very beneficial for their upcoming exams. We will have 4 short and 4 long cases. Short cases will be of 40 minutes each, and long cases will be of 1 hour each. We request the presenters to finish their history within 10 to 15 minutes to allow ample amount of time for discussion. A bell will be rung at 30 minutes for short case and at 50 minutes for long case, which will be a warning bell, and a final bell will be rung at the end of the allotted time. As we move on to the first case, I would like to welcome upon the stage our examiners for the first case. First, we have Dr. Srijit Parmeswaran, Professor and HOD, Department of Nephrology from JIPMER. So kindly take your seat on the stage. Next, we have Dr. Ram, Professor and Head of Department of Nephrology from SWIMS, Tirupati. So we are indeed fortunate today to have you both as our examiners, and we are very eager to learn from you. I now call upon our first presenter, Dr. Paromita Das from AIIMS Bhubaneswar. Kindly proceed to the stage and start with your case presentation.
Good morning, respected faculty and my dear colleagues. So beginning our today's case presentation. My patient, Mr. X, 64 years male, resident of Vellore, graduate retired policeman, and date of examination 9th of January 2025, with the chief complaint of patient had come for routine OPD checkup. Moving on to history of present illness, I would like to begin my history from 2007. As a part of his routine annual employment screening, patient was diagnosed with diabetes mellitus in 2007 at 46 years of age. He was asymptomatic at that time and he was started on oral medications for the same. He does not recollect any abnormality in kidney function at that time. He was asymptomatic till 2017 when he started having insidious onset, gradually progressive, generalized weakness and swelling of the feet which extended up to his ankles. He was evaluated for these complaints at Madurai Hospital, and he was told to have a serum creatinine of 2 mg per deciliter at this time and some protein leak in his urine. The value he does not remember. His medications for diabetes were increased and new oral medications were added. At this time, he was not having any other complaints of shortness of breath or chest pain or any shortness of breath. At this time, he was also, his blood glucose levels as per patient was well controlled and he did not have any insulin requirement. He also recollects at this time he had some tingling sensation in both lower limbs and was which were told to be due to diabetes, and he was also started on medications for the same. A few months after this, he started having bilateral gradually progressive painless blurring of vision in both eyes, right more than left. And he recalls undergoing cataract surgery, sequential cataract surgery in both eyes over the next 7 to 8 months. And he also recollects undergoing laser therapy for these complaints at the during the same time period. Again, patient was asymptomatic till May 2019 when he presented to CMC Vellore with insidious onset, gradually progressive, shortness of breath, loss of appetite, and swelling of the feet. These symptom onset had been for the last 2 months and had gradually worsened till he presented here. There was no history of orthopnea. There was history of orthopnea, but no history of chest pain or PND. And he also noticed a decrease in his urine output over the last 10 days before presenting to the hospital. However, at this time, there was no history of fever, loose stool, vomiting, burning micturition, cough, or blood in his urine. He was admitted at this time in CMC Vellore and was found to have high blood pressure. He was told his serum creatinine at this time was 7 mg per deciliter and was advised hemodialysis initiation. Dialysis initiation was done through a right side neck temporary catheter. He was given dialysis 3 times a week during hospital stay, and he underwent a left forearm fistula creation 1 week after dialysis initiation. Dialysis was initiated through the fistula in the same hospital setting, approximately 3 weeks after fistula creation. He also recalls having undergone a kidney biopsy at that time, and he was told to have kidney disease due to diabetes. At this time, his urine output was around 100 to 200 ml per day, and he was discharged at this time with advice for thrice weekly maintenance hemodialysis. He continued to be on medications for diabetes, no insulin was required, and antihypertensives were given. He recalls that his blood sugar level at this time was also well controlled. He was planned for living-related kidney transplantation with wife as his prospective donor, the recipient's blood group being AB positive and the wife's blood group being B positive. However, during further evaluation, his cross-match test, he recalls his cross-match test coming to be positive, and on subsequent testing, again 2 more times, the cross-match test was positive. Subsequently, with further workup was being done and transplant was delayed by a couple of years. He finally underwent kidney transplant on 10th November 2021 via swap transplant, the donor being the wife from another CKD patient. The transplant happened at CMC Vellore. He could not recall the induction agent being given. He remembers having no complications during surgery, had good urine output in the immediate post-operative period, and he was discharged on 7th post-operative day with a serum creatinine of 1.1 milligram per deciliter. He underwent a protocol biopsy before discharge and was told to have normal kidney function. At this time, he was discharged with, he recalls being discharged with a triple drug regimen of Visolone, Pangraph, and Mycept, and he was continuing his antihypertensives and diabetic medications. 3 months after transplant, that is in February 2022, he was admitted with fever, temperature recorded being up to 103 degree Fahrenheit. Fever was associated with chills and rigor. There were no other localizing symptoms of fever. He was admitted for the same again in CMC, and multiple investigations were done. Patient recalls undergoing bronchoscopy and was finally diagnosed as having tuberculosis of the lung. He was started on medications for the same. He recalls being started on 4 medications at this time. For his kidney transplant medications, he says that Mycept was stopped at this time. Kidney function was normal throughout this time, and he was given TB medications for 1 year. He does not recall having orange urine after being advised TB medications. Patient was discharged around 2 weeks after, 3 weeks after diagnosis and initiation of TB medications. 3 months after this, around May to June 2022, he noticed a blackish discoloration of his left second toe. He does not recall any episode of trauma prior to that. He was again admitted at CMC Vellore, was found to have infection of his second toe, and after treatment with some medications, which he recalls as being some antibiotics, he underwent amputation of his right second toe, and he was prescribed some special footwear at this time. He was again discharged with a normal kidney function at this time. He completed his ATT 1 year later in February 2023. His kidney function was stable at that time. At this time, he recalls being started on a new drug, Azuran, and along with his previous medication of Visolone and Pangraph. Patient was doing well till August 2023, when he had asymptomatic rise in serum creatinine, which he recalls being 1.4 milligram per deciliter at that time. His blood glucose and blood sugar were well controlled. His urine output was normal. He underwent testing for BK virus. Counts were very high. He recalls the counts being somewhere around 90,000. He also underwent a graft biopsy at this time and was told to have BK virus infection of the graft. He recalls receiving a medication, intravenous medication, IVIG. He underwent monthly courses for around 3 months. There was some improvement in his count, he recalls, but they were not completely normal. After this, he was started on, after the 3 months of IVIG, he recalls being started on a drug called leflunomide, and he was continuing, has been on that drug ever since then. 6 to 7 months after treatment, his serum creatinine came down to 1.2 milligram per deciliter, which was his baseline. He was following up on monthly basis at CMC Vellore. Again, in June 2024, during routine follow-up, he was found to have increasing BKV virus counts in the blood. Kidney function at this time was, however, the same as before, and he recalls being started on a new drug, Cidofovir, for which he underwent monthly injections. The last injection was taken on 30th of December 2024. At present, patient is following up on a monthly basis, is asymptomatic, and he had come for his routine checkup in the first week of January. Current creatinine is 1.2 milligram per deciliter. Moving on to past history. So he's a diabetic since 2007, hypertensive since 2019. No history of any coronary artery disease, stroke, seizure, no history of claudication, no past history of surgery, no history of blood transfusion, no prior history of TB before transplant. He has a history of COVID infection in February 2020 at the time when he was on maintenance hemodialysis, for which he was hospitalized for around 7 days and had oxygen requirement. In personal history, he is a reformed smoker. He has a duration of around smoking of 25 years. He quit smoking in 2010, so total pack years consumed was 6.2. He has no other addictions. He's on a mixed diet. There are no no change in bowel bladder habit throughout this entire course of history. No high-risk behavior, no IV drug abuse. For vaccination, he recalls having completed his hepatitis B vaccination 4 doses prior to transplant, and also a pneumonia vaccine which was given pre-transplant when the patient had been on maintenance dialysis. In family history, both his parents, both his mother and father have diabetes and hypertension. Both parents died, he says that both parents died of diabetes-related complications around 72 and 74 years of age. However, he does not know if there was any kidney disease in either of his parents. He has 4 elder siblings, 2 sisters and 1 elder brother. All of them have diabetes. His 2 elder sisters were also found to have kidney disease around 45 to 46 years of age, and they had kidney disease and they expired soon after that. No history of, he does not recall history of any dialysis being given to them. There is no history of TB contact in the family, and he belongs to a middle socioeconomic class. Sir, should I move on to examination?
What's your final diagnosis?
Sir, from my history, it's a case of...
no, it's okay. Give your final diagnosis.
Okay. CKD-T, native kidney disease, diabetic kidney disease, living kidney transplant by kidney paired donation on 10th November 2021, post-transplant pulmonary tuberculosis, post-transplant BK virus nephropathy, diabetes mellitus, hypertension.
You told that this patient had a habit of smoking.
Yes, sir.
How smoking affects kidney?
Sir, it can predispose to atherosclerosis. So it can cause atherosclerotic vascular diseases in the form of like renal artery stenosis or microvascular changes in the kidney, and it's also associated with nodular glomerulosclerosis. So can cause proteinuria.
What's the difference between the nodular glomerulosclerosis of smoking versus diabetes? How do we differentiate?
Sir, clinically and...
No, not clinically, pathology.
Histopathologically. The diabetic glomerulosclerosis, they'll be the nodular glomerulosclerosis seen in diabetes, classical known as Kimmel-Stein-Wilson, they'll be PAS positive and silver positive stains. They'll be associated with other changes like thickening of the basement membrane.
Which is the earliest change in diabetic nephropathy?
Sir, in class 1, there'll be on light microscopy, there are no changes. Initially, there's only electron microscopy changes of thickening of basement membrane, and the earliest light microscopic change is mesangial expansion. So these changes will not be seen in glomerulosclerosis associated with smoking. It will only be a nodular glomerulosclerosis pattern.
What's the staining pattern in smoking?
Sir, they are...
Nodules of smoking, how do they stain?
So they are PAS positive, silver negative.
Is there any other condition where the nodules are silver positive? This patient has been diagnosed diabetes in 2007, but in 2017,
yes,
he had his first creatinine 2.
Checkup, yes.
Later in which year he got creatinine 7?
Sir, in 2019, May 2019.
Okay, over 12 years he has progressed to end-stage renal disease.
Yes.
Is it the proper progression rate of diabetic nephropathy?
Sir, in type 2 diabetes, usually in type 1 diabetes, the progression is slower. So there's a onset after median duration of around 10 to 15 years, patients start having renal dysfunction. However, in type 2 diabetes, Usually, patients also have other risk factors like dyslipidemia and hypertension at onset. So usually, kidney disease is seen closer to the onset of diabetes.
No, but what's the rate of progression in type 1 diabetes? Which we can later correlate with the type 2 diabetes. But what's the rate of progression in type 1 diabetes?
So it takes around 10 years of...
What's the rate of loss of GFR per year or per month?
So loss of GFR per year is around 7 to 8 ml per minute per 1.73 meter body surface area in type 1 diabetes.
How do we know that this particular patient is in particular stage of the diabetic nephropathy?
Sir, this patient or
Not
sir,
in general.
in general?
In general, if there is a diabetes patient, how do we know that he is in particular stage?
Sir, we have to look at the, in type 1 diabetes, usually the progression is more classically defined. So initial stages, patient will be asymptomatic, and if we check the GFR, there'll be it will be supranormal. Gradually, there'll be onset, like in the initial stages, there will be only mildly increased albuminuria, kidney functions, GFR will be normal, and gradually patient will have onset of hypertension with gradually increasing albumin
What
levels.
do you call this staging?
So Mogensen's classification in type 1 diabetes.
What are the stages? You please give the stages.
Stage 1 is stage of hyperfiltration. Stage after that it is silent, then incipient, overt nephropathy, and end-stage kidney disease.
Okay, how do we know that one particular patient is in silent phase?
So in silent phase only by checking.
When he is seen for the first time?
So if he has a diagnosis of diabetes and by the checking the GFR and absence of any end organ damage at that time usually, so there's no hypertension, there'll be no albuminuria, and GFR will be normal, and GFR will be supranormal.
No, silent phase.
So silent phase will be like GFR will be normal between 90 to 120.
How do we know? It could be a normal stage also.
Yes, sir. So by like we have to there can be mildly increased albuminuria.
Silent
And
phase, no albumin.
in only by kidney biopsy at this point
No
of
biopsy.
time.
Clinical. This patient, why he has undergone biopsy? He has been a diabetic for 12 years. What was the indication for biopsy?
Sir, at that time he had not undergone a biopsy prior to that. Like even when his serum creatinine was 2. So at this time, like, and there was this, like, after a long 10 years of almost asymptomatic period, there was because he does not know his creatinines in between. So there was a sudden rise, if we assume, like at 7 milligram per deciliter. So to rule out any non-diabetic kidney disease at that time.
Is there any method by which we know that one particular patient is having sudden deterioration in renal function?
Sir, I didn't get your question.
Is there any method by which we know that one particular patient is having sudden deterioration of renal function?
So like clinical, there be sudden onset of
How do we
symptoms.
There is no apparent obvious reason for the deterioration, but the creatinine has risen. That's how most of our patients present. Their previous value would be around 3. After 6 months, the creatinine would be 7. No obvious acute factor. How do we know that this particular patient has slipped from the natural progression? What is the method to be used?
Sir, if we have his GFR, creatinine and GFR serial monitoring, and with the albumin levels in between, like from the baseline gradually monitoring, only then we'll be able to know whether it is a natural progression of the disease or there has been some superimposed insult or any other factor which has led to the sudden worsening. And maybe that is
But
why
you
the...
didn't tell the reason for biopsy.
Sir, he underwent biopsy to rule out any superimposed like disease, any non-diabetic kidney
After
disease.
12 years of
And
diabetes, do we recommend biopsy to our patients?
No, sir.
Then
Sir,
he
he
has
does
undergone.
not recall if there was any urinary abnormalities like microscopic hematuria or RBC cast at this time. Patient could not say. And if he's planned for kidney donation, prospective kidney transplant, so maybe we would like to know the native kidney disease.
What are the indications of biopsy in
Sir,
diabetes?
in diabetes. So if there is sudden worsening of kidney function, like presenting as RPRF, if there is, if the duration of diabetes is less than 5 years and the patient is having nephrotic range proteinuria, and
Is it nephrotic range proteinuria?
nephrotic, yes sir.
Is it nephrotic range proteinuria or proteinuria something else?
Sir,
What is the exact range of proteinuria at which time we need to consider a non-diabetic renal disease?
sir,
It's not nephrotic range.
so like Persistent, more than 8 gram usually
Hmm.
we take as the cutoff to biopsy patients.
What is the rider? Proteinuria of more than 5 to 8 grams per day with use of, what is the rider? That has not come down even with the use of,
Maximally optimized ACRBs. And if there is also there is proteinuria without any kidney, without any deranged GFR, or there's sudden worsening of kidney function, or if there is a microscopic hematuria or RBC CAS, and the duration of diabetes is less than 5 years when these symptoms are happening,
no relation with retinopathy?
and absence of absence of diabetic retinopathy.
What's the correlation?
Sir, in type 1 diabetes, almost 90% patients with retinopathy will have nephropathy, whereas in type 2 diabetes, only 50 to 60% patients with retinopathy will have nephropathy.
He was worked up for transplant. 3 times the cross match was positive. What was the cross match done?
Sir, he does not recall.
Okay,
He only
what
knows
is the usual cross match we recommend for the first time?
Sir, the first screening test will be a cell-based assay, so a CDC cross match.
Can you
And
recite the steps in CDC?
yes, sir.
Can you recite the steps in CDC cross match?
Sir, the recipient serum is is taken, and the donor lymphocytes is incubated with the donor lymphocytes. So if there is any antibody in the patient's serum, it will bind to the donor cells, donor lymphocytes. Then a complement containing serum is added, followed by addition of a IgG antibody binding primer. So if it's binding, there will be complement lysis, which will be visualized under the slide as lysis of the cells.
Which microscope is used?
Sorry.
And what would be this? What would be the
It's
change
on-
in the slide if the cross match is positive?
What will be this?
Change in the slide if the cross match is positive.
So there will be lysis of the cells,
What percentage?
more than 20%.
How do we know lysis? How do we recognize the lysis?
So with the control,
Is there any method by which the lysis can be highlighted?
sir,
On which
Augment-
on which surface all these tests are done?
it's a cell-based platform.
Which surface? Surface. We use a particular surface for that. It goes by the name of the first discoverer. The fluid-
Terasaki plates.
How much fluid? How much donor lymphocytes are taken? How many donor lymphocytes are taken?
So
How
this
many number?
this I don't know, sir.
Okay, if the cross match is positive, and if it is in a high risk transplant, imagine the patient has undergone 2 transplants before, what is our next step?
If the patient is already highly sensitized and has history of previous transplants, so so for workup or for the transplant plan, we have to calculate the we take out the calculated PRA, and if that it will be already this is
PRA
positive,
is
so
for a deceased donor.
deceased donor.
Not for deceased. This is particular for a living donor.
So if you are planning him further for living donor transplantation only, so then if there's a prospective living donor, then he has to undergo desensitization protocols if we are planning to go ahead with living.
Don't we further investigate?
And DSA testing has to be done. So we have to highlight the antigens against which the patient is sensitized.
How do we check DSA? What's the method?
So single antigen bead is ideally recommended if affordability is not an issue. Luminex platform single antigen bead.
In single antigen bead, do we use complement?
In single antigen bead, no sir.
Then this is a complement dependent test, no?
So CDC is a complement dependent test.
The test in CDC has come positive, but we are using a non-complement based test to know the antibody. How is it possible?
Sir, complement, there are antibodies to which cause donor specific antibodies can be both complement fixing and non-complement fixing antibodies.
We are not bothered about non-complement fixing. The damage is mainly because of complement fixing.
So we also
No, I'm asking about the test. CDC is a complement based test.
yes sir.
Luminex or single antigen bead is a non-complement based test, but the same test is being used to identify DSA. How is it possible?
Because this will single antigen bead will just detect the antibodies in the donor, so they can be both complement fixing, and it will detect both complement fixing and non-complement.
What is the size of the bead in Luminex? Size of the bead.
Sir,
What is it made of? Okay.
silicon bead, sir.
Okay. He underwent kidney paired donation on 10/11/2021.
Yes, sir.
Okay. If there were to be in a country or an area where there is a flourishing kidney pair donation, which type of transplant may not flourish? Studies have shown that another particular type of transplant may not flourish. What is that particular transplant that may not flourish?
If there's a good kidney paired donation transplant, so ABO incompatible transplants may not
Why
be.
is it so? Why these two are competitive, ABO incompatible and kidney pair donation?
Sir, ABO incompatible transplants, like it, if both have less inferior, they have both inferior outcome compared to living kidney donation.
I didn't understand.
So compared to living kidney donation, ABO incompatible has inferior long term, like there are differing data, so we usually try to avoid ABO.
Why kidney pair donation is more better survival than ABO incompatible?
So because we are getting a donor who is as closely matched to the recipient as possible, so we are also excluding the possibility of ABOI or an HLA incompatibility. So we'll obviously try to avoid any incompatible high immunological risk transplant and go for a low immunological risk transplant.
Okay. The induction agent, what are the possible induction agents we could use?
So this is a patient with high immunological risk with cross-match positive, so we will use rabbit
What was the cross-match
ATG.
positive with this kidney paired, outside donor, means outside the family donor? What was
Sir,
the cross-match test?
This was negative.
No, which was negative? CDC?
Sir, again, he only knows that cross-match was negative. CDC or flow, he does not know.
Then can you term him as an high-risk donor, high-risk recipient now?
Yes, sir.
Can we call him as an high-risk recipient now?
So he's undergone. He's undergone one transplant with.
No, this is first transplant.
This transplant. So with positive cross-match.
Who are high-risk recipients?
So anybody who has like a previous transplant or previous sensitization history and has donor-specific antibodies has cross-match positive.
How do they acquire? How
Sir,
do they acquire the antibodies? Who are those high-risk patients?
So in those who have undergone a previous transplant, pregnancy, and any infections, also severe infections can also give rise to these allo antibodies.
Which infection? Which infection?
Sir, and like any severe like viral or infections will give rise to this.
What are the possible induction agents we could have used?
So in a high immunological risk, we would like to go ahead with ATG as the induction agent. Otherwise, like in low immunological
What's the
risk.
recommendation of use of induction agent?
Sir, ATG is approved only as FDA approved for only treatment of rejection and not as it is an off-label agent for induction. So for induction, FDA approved for induction therapy is basiliximab, and we also have like grapholon ATLG. But again, like in since this is already a high-risk transplant, so probably ATG was used as an induction.
Between rabbit ATG and horse ATG?
Sir, equine ATG has more hypersensitivity reactions and more incidence of cytokine release syndromes rather compared to rabbit ATG.
What are the precautions to be taken before giving ATG?
Sir, we usually we have to like it is given in a central line, never in a peripheral line, and we pre-medicate the patient with steroid and antihistaminics prior to giving it. We start it off at a lower dose, see if the patient is tolerating well for around 15 to 20 minutes initially, and then go up to the dose.
Is it a monoclonal antibody, polyclonal?
It's a polyclonal antibody.
Are there any monoclonal ones in the past?
Sir, muromumab, which is the OKT3 anti-CD3 antibody.
After ATG, which type of infections usually flare up?
Sir, like post-transplant, these patients are
Post-transplant.
at a risk of viral infections like CMV and BKV, and there can be
Specific for
CMV reactivation of hepatitis B. And
Specific for ATG. Which type of infections specifically flare up after ATG?
opportunistic viral infections.
Which type of infections specifically flare up after cyclosporine?
Right.
After introduction of which immunosuppressive agent BK virus has flared up?
So, CNI, tacrolimus.
Which infection has specifically flared up after basiliximab?
Sir, CMV and malignancies.
CMV flares up
So-
for all, but which infection specific?
Specific, then
Okay, then he was given tacrolimus, MMF, Vislon.
yes, sir.
Okay, and also undergone good urine output. If once a transplant is done, what are the three possible outcomes clinically? Immediately in first 2-3 days after the transplant, what are the three possible outcomes?
Patient can have a good renal function. There can be a slow graft function or a delayed graft
How
function.
do we define each of them? Okay, forget about good urine outputs, delayed and slow graft. How do we define them?
So, delayed graft function is usually like if any patient is requiring dialysis after undergoing kidney transplant for maintaining kidney function, that is a delayed graft function. Slow graft functions, and there are multiple definitions. So, some are defined by creatinine, some are defined by GFR. So, mostly it is like the creatinine should, like there should be a twofold rise every third day onwards. And if the serum creatinine remains above 2 milligram per deciliter at the end of 1 week, that can be one definition of slow graft function.
Okay. This patient had good graft function.
Good graft function, yes.
Then he was continued on tacrolimus, MMF and Vislon on 7th day. From 7th day to 3rd month, there was no event.
No, sir. From
No
the
other
third
event
month,
has happened.
till 3rd month, there was no event.
Huh?
Till the 3rd month post-transplant, there was no event.
Okay, but if there were to be any adverse events to happen within first 2-3 months, what are those events which we should be careful about?
Sir, in the immediate post, there can be vascular and surgical complications in the immediate post-transplant period.
No vascular.
Non-medical
non-surgical.
complications.
Non-surgical complications.
Non-surgical complications. So, sir, in the first 3 months, usually there can be infections like from the indwelling from indwelling stent, urinary tract infections, or because the patient had a hospital stay, pneumonia at that time. And there can be donor-derived, they are rare, but sometimes viral infections from donor-derived HSV and all can flare up, and candida infections.
If there were to be a pneumonia in a patient, a post-transplant patient, based on the radiograph, can we identify the diagnosis?
Sir, if
Radiograph and rate of the progression of the opacities.
sir, in PCP pneumonia, there'll be a
PCP would not happen in first 1 month.
in the first 1 month. Sir, if fungal infections, but usually candida will also not happen at that time. So, any hospital like bronchopneumonia, it will be a diffused pattern of involvement.
Okay. Imagine a patient has developed fever, leukopenia after 1 month of transplant. What would be the first diagnosis?
Fever and leukopenia in 1 month post.
After 1 month.
After 1 month post transplant.
Chill, fever, leukopenia after 1 month.
CMV infection.
Okay, but how do we know that particular patient is having CMV? What would be the first investigation? Once we suspect CMV, what would be the first investigation to be done?
Sir, if we have a pre-transplant, if we would have checked the positivity status of the donor and the recipient. So, if the donor was positive and the recipient was negative, and there's the highest risk of CMV reactive infection, new infection in the donor.
Donor is
in
positive
recipient?
and recipient is also positive?
So then it can be a super infection or a new infection,
How
like
do we
reactivation.
Shall we go
So-
ahead with the transplant if the donor is positive and recipient is positive?
Yes, sir.
In which type of combination we usually withhold transplant for some time?
Sir,
Donor-
active infection in the recipient is a contraindication, like
That's a
usual-
contraindication
indication
for
for
any
transplant.
transplant. But which combination of CMV in donor and recipient we usually postpone transplant? For which combination?
Sir, in both D plus and R plus of.
D plus and R plus? Or D?
Sir, because in D plus R minus we have to give prophylaxis for 6 months post transplant. So, like.
Okay, that's not post transplant. I'm asking pre transplant. If they don't, if the recipient is positive. Pre transplant, if we know, how do you manage that?
Sir, we have to check if the patient has any active sign and symptom of infection before like thorough evaluation, like his
What is the
TLCs.
manifestation of a CMV in a normal person like me?
So usually it manifests in immunocompromised patients only, and otherwise it just presents as a
What is the treatment of an CMV in a normal person like me?
Sir, if we manifest, like it can present the general as treatment for. So the same, like if it is symptomatic CMV, then we will treat with antiviral. Even
so
if it is
treatment of a person, of a recipient who is found to be CMV positive
symptomatic
just a week
CMV
prior to the transplant?
So we delay transplant and we treat him with antiviral. If it is tissue invasive disease, if it is non-tissue invasive disease, then we have to give oral valganciclovir. If it is tissue invasive disease, like we treat with intravenous.
Okay, what are the manifestations of CMV in post-transplant?
So it can be asymptomatic, like only CMV syndrome in the form of fever, leukopenia, chills, transaminitis, or it can be invasive CMV disease, which can affect any organ like pneumonia or hepatitis or pancreatitis or graft dysfunction or pneumonia.
Is there any vascular manifestation of CMV?
Sir, it can usually it infiltrates the organ which is transplanted. So there can be, though the tubulointerstitial compartment is most commonly involved in the kidneys, there can be rare vascular. It can precipitate vascular rejection like ABMR. CMV infection can itself precipitate rejection in the form of ABMR with
CMV
vascular.
Can precipitate in rejection. That's slightly controversial. But is there any other vascular manifestation of CMV? I specifically asked for a vascular manifestation.
Sir, retinitis.
Okay. Then after 3 months, he was diagnosed with tuberculosis because he had some fever.
Yes, sir. Yes.
Some fever. What would be the usual site of infection of tuberculosis in transplant recipients?
Sir, pulmonary TB.
Okay. If there were to be the pulmonary tuberculosis, nowadays straight away they are going to fibro-optic bronchoscope, but if that was not available for some reason, what are the other methods by which we try to get the tuberculous organism diagnosed?
Sir, we go initially sputum and induced sputum. If patient
Both
is not
of them are not
possible, then a mini BAL is done usually.
Mini packer.
Mini bronchoalveolar lavage, like only upper respiratory secretions are taken.
That's also okay. That was also found to be futile.
And we can send blood culture, like liquid cultures from the blood.
Tuberculosis usually doesn't grow in
will not grow. So other, like we have to look for any other evidence of infection for TB, and we search for lymph nodes and send a biopsy from that, or we look for evidence of.
You told that.
So you want specifically for pulmonary test, specifically for pulmonary.
Yes, that's what I'm asking. You told the same thing.
Okay.
Why you told about some orange urine?
Sir, because these TB medications, they are enzyme inducers, so they'll have interaction with the transplant medications. So,
which TB medication?
Sir, isoniazid and rifampicin.
Oh, all the while I thought only rifampicin.
So rifampicin is, I took the history because mainly of rifampicin, that's the strongest enzyme inducer.
Why
so
rifampicin interferes with which medication it interferes with? Rifampicin interferes with which medication?
So CYP is a CYP3A4 inducer, so the CNI levels are going to be, like he was on tacrolimus. So any enzyme, if it's an enzyme inducer, it will reduce the levels of tacrolimus in this patient.
Okay, it has no effect on cyclosporine.
Yes, sir. I am saying because he was on tacrolimus.
No effect on everolimus?
Sir, Yes, on everolimus as well. So this patient, he was on tacrolimus. So this, it interacts with both CNIs and mTOR inhibitors, because mTOR inhibitors are also metabolized by CYPs is 3, 4 and 5.
Okay, if there were to be a condition where we would be forced to give rifampin, what will we do?
If we were forced to use rifampicin,
We are
then
compelled to give rifampin a particular transplant recipient for some reason. What would we do?
sir, if it's early in the post-transplant period and we would like to keep the patient on triple drug immunosuppression, so mTOR, early post-transplant, usually mTOR inhibitors are also not used. You have to like modify the CNI levels more judiciously, and maybe it will require, because it will require increase in the drug levels.
How much percentage we need to increase?
Sir, around 30 to 40% increase when we are prescribing any enzyme inducer.
This patient also had an amputation of the toe.
Yes.
What is the percentages of toe? I mean, what would be the outcomes if any patient undergoes an amputation after transplant when compared to the patient who has not undergone the amputation? Is it a kind of a sinister? If it were to be sinister, what is the type of sinister? What is the type of influence it had?
Sir, on the post-transplant
outcome.
course.
Patient survival.
Sir, usually like pre-transplant, if the patient had these complications, that would have been less sinister than post-transplant. So, but sir,
no, I'm asking about the patients who have not undergone amputation.
yes, like who have undergone compared post-transplant, who have undergone amputation versus those who have not undergone any amputation. So without an amputation, it's obviously it is better than those who undergo amputation, but the graph.
How? It's obvious.
Like the long term.
Obvious, but how it is better?
So it means that the patient will is not if
after 1 year
not having
after 1
microvascular.
year ATT was stopped, but usually in many of our centers, no, we continue something else after 1 year. What is that we continue?
So all his medications were sometimes isoniazid may be continued for a prolonged period of time.
For how long?
So 2 to 3 years it may be continued.
If particular patient develops an isoniazid hepatitis, what is the replacement drug for that?
For isoniazid hepatitis. Sir,
he was given Azaron after August 2023.
yes, sir.
Huh?
After
replaced with MMF was
MMF
replaced
was
with
stopped,
MMF.
and yes.
How Azaron and mycophenolate mofetil, they differ in their actions, mechanism of actions?
Sir, both are anti-proliferative agents. So mycophenolate mofetil inhibits de novo purine synthesis, and basically both of them act downstream in the activation of the T cells. So mycophenolate mofetil is an inhibitor of de novo purine synthesis inhibitor and inhibits replication of B and T cells.
In this patient, one pyrimidine synthesis inhibitor was also used. What was that?
Leflunomide.
Why
Later on it was added.
Why in this patient mycophenolate mofetil could have been replaced with leflunomide, no? Why it was not done?
Sir, initially only.
Now also, we can withdraw Azaron and replace continue leflunomide. That would work for it. Because it's only a pyrimidine.
Sir, now
pyrimidine
he's
versus
on both
pyridine.
the drugs. He's
he
on.
is continuing both the drugs?
Sir, he's Azuran is being used as the triple immunosuppression in place of mycophenolate, because we have data on
but
that.
Purine and pyrimidine doesn't make difference to us, no? Finally, we require removal of
Antimetam. So, but like for BK, after BK virus was diagnosed, he has been started on leflunomide, and prior to that, as the triple drug
now,
regimen.
At present, why he should be on 4 drugs? Can we withdraw Azaron?
We can stop Azuran in this case.
Possible?
So now he's 3 years post-transplant, though he's a high immunological risk, but his graft function has been stable throughout.
It was not stable.
Stable, like with barring one episode of BK virus nephropathy. So maybe that is why they have kept him on.
No, I'm asking how leflunomide performs vis-a-vis Azaron. That's what I'm asking. You do not worry about all these things, peripheral things.
Sir, as a
one is a purine synthesis inhibitor, another one is a
pyrimidine synthesis inhibitor.
Can we replace a purine synthesis inhibitor with a pyrimidine synthesis?
No, sir.
Okay, then he had a BK virus. How BK virus affects kidney allograft? Can you name one renal disease which is named after a patient? named after a patient. BK.
B.
BK is the first patient who have been diagnosed with BK virus. It's named after the
Okay.
patient BK. Can you name one renal disease which is named after the first description given?
Like, sir, renal.
Any renal disease which has been named after one particular description, one great personality has given the description of that disease.
Sir, anti-GBM disease. Which
Bright's.
was-
I'm looking at Bright's disease. Okay, you can end up.
Couple of things before we close. In the diagnosis, because of lack of time, I would like to know this patient had an amputation, and I think you didn't bring that in the diagnosis.
Okay,
This
sir.
patient probably has peripheral vascular disease, and I think you mentioned about some numbness of the lower limb.
So yes, in the initial phase.
Yeah, so probably he has peripheral neuropathy,
Neuropathy
also. So
as well.
it is better
So,
to bring.
sir, the complications I should add in the diagnosis.
Yeah, so the diabetes, he has diabetic complications, also nephropathy, likely peripheral neuropathy, then he has peripheral vascular disease,
Peripheral.
right? So that was missing in the diagnosis.
Okay.
And he's probably sensitized also, not probably sensitized, so that also
Should be added.
can
in.
come in the diagnosis.
Okay.
Couple of other things. So this patient had TB post-transplant. Suppose you want to reduce the incidence of TB in your transplant patients, how to go about it?
Or if
You are having a transplant program and you want to minimize the incidence of TB in your transplant patients. What should we
sir,
do?
we screen for more evidence of latent tuberculosis before going for transplant, but
Is it
it's an
recommended?
endemic. It's in our scenario, it's an endemic country, so most patients will come positive. So
Why are you saying it's endemic? How common is latent TB?
latent TB, sir. So we look for the disease, and but we have to do active symptom and screening
No,
for that.
I'm asking for a reason. So, do we know the prevalence of latent TB in the general population in India?
Latent TB in the
Latent TB, I'm asking, not active TB. Latent TB prevalence. You can
Sir,
go and check. There is data. There is
okay.
a national survey based on a study done in Gujarat. Okay, that study found 30% in Gujarat, but the national projection is around 20%. So 20% of Indians are
Patients.
having latent TB. Latent TB, I'm telling. Is there any
So-
recommendation on screening for latent TB in, say, before transplant? What is the, is there
Yes, sir, there is like
what is
either
the recommendation by NTEP, National TB Elimination Program? Do they have a recommendation on this? You can go and check that. Okay, all
we
dialysis
have
patients
to
are supposed to be screened.
undergo.
Yeah.
Sir,
So
IGRA
suppose
testing.
you, how are you supposed to screen? What is the recommendation in the NTEP?
Sir, symptom screening has to be done, and any
No,
symptom
see,
direct
this is
diagnosis
latent
and
TB. I am asking about
Achha,
latent
sorry,
TB
sir.
screening. cannot be
IGRA
license.
testing, TST and IGRA testing.
No, both are recommended.
Uh,
Okay, you can go and check that. Okay, I think you are not. You can go and check it's recommended. What is the test to be done? And suppose you find somebody to be positive, what is to be done? You can go and check, right? This patient had, I think, transplanted in 21, and he had rise in creatinine asymptomatic in 23. Right?
24.
24. Yeah.
23,
So
yes.
suppose otherwise uneventful transplant for first 2-3 years, and then you find that there is asymptomatic rise in creatinine. What are the possibilities?
Sir, after the first 1 to
No, 3
initial-
years, no? This
3 years
patient is
post-transplant. Yes, sir.
So you didn't give any DD for that. You straight away told us it is
Hmm.
BK virus.
Hmm.
What are the differential diagnoses you would
Of-
like to consider?
At this point of time, sir.
Yeah.
Yes,
Not at this point
for,
of time. He had rise in creatinine to 1.4 in 23.
Hmm.
And that is when he was found to have
BK virus.
BK virus. So,
So,
so
BK
somebody
virus.
has post-transplant uneventful for 3 years, and then there is gradually rising creatinine. What are the possibilities?
Other than BK virus nephropathy, sir, there can be chronic CNI toxicity at this point of time, vascular complications in the form of renal artery stenosis, and chronic rejection. Acute on.
So one is CNI toxicity. Then you are telling graft renal artery stenosis. and-
rejection, any.
What sort of a rejection?
Sir, mostly antibody mediated rejection, 3 years post-transplant.
What sort of an antibody mediated rejection do you mean?
Chronic antibody-mediated rejection if
Chronic
it's an asymptomatic rise.
Okay, all right. Anything else? What are the possibilities?
Sir, any other opportunistic infections? To be
Graft
mostly
dysfunction, asymptomatic.
Asymptomatic.
You
graft.
basically are finding the
And-
only thing you are finding is a rise in creatinine, nothing
Creatinine.
else.
And BK virus nephropathy.
BK virus, anything else?
Nephropathy.
What all things should we think about? So you can go and check that also. Okay, late graft dysfunction. Would you like to think of a recurrent disease, for example,
Sorry,
de novo disease?
So recurrent disease in the graft.
All right, fine. So, how do you make a diagnosis of BK virus nephropathy? What are the risk factors for BK virus nephropathy?
Sir, there are some donor factors, some recipient factors. So if the donor, depending on the genotype of the
Any
donor.
other categories there? So donor is there, recipient related factors. Are any other category of risk factors is there?
Sir, transplant, peri-transplant courses like induction
Okay,
agent
so
that is used.
okay. So what are the donor related, what are the recipient related, what are the transplant related risk factors?
Donor related factors are the active shedding of BKV in the donor, the genotype of the virus in the donor, and the degree of mismatch between the donor and the recipient. And
What do you mean by degree of mismatch?
so the serotype difference, genotype difference between the recipient and the donor.
Okay, all right.
And the recipient factors being elder patients, male patients, somebody with diabetes, and those who have certain so donor also, sir, HLA-C is a HLA-C7 is a risk factor, and among recipients, elderly males, diabetes, then certain protective HLAs are also there as rather than risk factors, and use of ureteral stents, and if the cause of the kidney disease was in pediatric population, if it was an obstructive uropathy.
Okay, all right.
And transplant factors being use of induction agents like ATG, use of steroids, any treatment of rejection, any active rejection episodes that were treated, and use of ureteral stents.
Okay, all right. So how do you make a diagnosis?
Sir, we have to, usually screening is advised anyway for BKV post-transplant.
What
So,
is the recommendation for screening?
Sir, it's monthly for the first 9 months, and thereafter every 3 months till 2 years of transplant. And in children, it should extend up to 3 years, the routine screening.
Okay, all right. This is
And this is the BKV, this is when we detect it in the blood. So the BKV DNA, what we call. So if there's a, the value is 1000, we are supposed to repeat it after 2 weeks to see if it is persistently high. Then-
whom will you screen? You are telling screening once in a month for 9 months?
So routine screening post
Okay, all
transplant.
right. Okay, fine. All right, go ahead.
So if the repeat titers are also more than 1000 2 weeks later, or it is an increasing trend, then it's a probable probable BKV disease. And whenever there's a graft dysfunction or there is any other sign like any hematuria or proteinuria, then graft biopsy also has to be done for a diagnosis of BKV nephropathy.
What will you look for in the graft biopsy?
So there'll be cytopathic effects and tubulo-interstitial inflammation and fibrosis. So among the cytopathic effects, we look at the what we classically describe as the ground glass inclusions with
Is there any staging or something you are aware of?
yes, the BAF classification where they see the PVL staging, like the percentage of the tubules that have been involved,
Okay, all right.
the three
What else?
and
Anything else in
the chronic interstitial.
All right, fine. Okay, good.
fibrosis.
So anything else in the biopsy you would like to?
And the direct quantification by DNA in situ hybridization of the DNA to detect, because and immunohistochemistry by IHC, which will show SV40, but SV40 can be positive with other viruses like JC and SV simian virus 40. So then specific in situ hybridization for the BK virus DNA in the graft.
All right. Fine. Anything else?
Sir, in the and
For
the
diagnosis. One is you are doing biopsy, one is wiring. Anything else you can do?
sir, viruria can be done
Suppose you are telling
and urinary analysis to check for decoy cells and Hoffen. So the decoy cells are non-specific.
Fine. All right. So you have made a diagnosis of BK virus nephropathy. Can you tell us how would you like to treat the patient? This patient had, right?
Yes, sir. So we check the titers if it's more than 1000 and increasing over the next 2 weeks. If we are finding an increase, or directly in the first time we see that it is more than 10,000, so it's an indication for treatment. So depending on whether and BK virus nephropathy is obviously an indication for treatments. So depending on whether the patient has low immunological risk, so if it is low immunological risk, we can directly reduce one immunosuppression or even stop it. Mostly we start by reducing or stopping mycophenolate. And if the patient is of high immunological risk, then if it is not, it was at the baseline, if it was not more than 10,000, it was somewhere around 1,000, then we repeat. If it is worsening, then we go ahead with reducing the immunosuppression. And we have to follow the BKV counts around 2 to 4 weekly after that.
How would you reduce? You are saying reducing.
So 50% reduction of MMF or discontinuing altogether.
All right.
And after that, if that doesn't work, and if there's a graft dysfunction is worsening, and if there is progressive rise in the PCR, DNA PCR levels, so then we have to check if there is any concomitant.
When will you say that the viremia has improved or worsened? Either way.
So there's
you reduce the MMF, right? When will you recheck?
So 2 to 4 weeks after, so depending on
you
how it's
recheck
available.
after, say, 3 weeks or 4 weeks. When will you say, yes, yeah, it does work?
So there's a 2 log reduction in the counts, in the quantitative PCR.
All right, okay.
And
check that, all right, fine, okay.
Stabilization of the graft function.
Suppose it has not improved.
So that we have to see if there is concomitant rejection or there or not in the biopsy. If there is normal. So then we have to go ahead with, there are multiple medications which can be given.
Reduce the MMF 50%, you are reaching after 4 weeks, viremia has not changed. What next?
We stop MMF.
Okay.
If it's stop MMF, we have to then move to the CNIs.
You do everything together or one by one?
So sequentially.
Sequentially. So can you quickly tell the sequence? We don't have time.
So we
15%, then 50%, then you stop.
50 stop MMF. Then we reduce the CNIs.
Okay, how much?
Sir, again by 30 to 50% reduction in the CNI dose. You
go by dose or trough levels?
Sir, trough levels.
Okay, what is the trough level recommended for tacrolimus when
Sir,
you are treating BK virus?
Sir, between 3 to 5 nanogram per ml.
Okay, all right. Cyclosporin, suppose the patient.
Cyclosporin 50 to 100.
All right, so let's not prolong the discussion. There is a recent consensus which has come. I think you can go and read that. All these issues are addressed. It came few months back in transplantation.
Yes,
okay, all these levels and all are mentioned in that. You can go and read that.
Yes. So and after that we can if that is also not working,
right,
then
no, I'm not saying
okay.
that you don't know. I'm just trying. You don't have time.
Sorry.
Our time is up, right? 5 minutes. Okay. So this patient, you are telling is sensitized. Why do you think he is sensitized? How did you find any reason for
Sir,
it?
no, other than he's had a asymptomatic course. There was no history of transfusion. This is first transplant. Only one episode of severe likely severe COVID pneumonia, which required hospital admission and ICU admission. Other than that, there's no history of which will predispose the patient. Elderly patient. Yes,
what
sir.
all history did you ask?
So history of infection, any previous transplant, and any blood transfusions in the past.
All right,
not.
but you mentioned blood transfusion. Other things I don't remember you mentioning.
Yes,
You
in
mentioned.
past history.
Okay, maybe I missed that. So what about COVID? Somebody on dialysis is developing COVID. What do you think will happen?
The prognosis is poorer compared
How
to
poor?
poor. So I have to see.
Okay, so what is the seroconversion rate? Suppose you vaccinate the patient. Now I think everybody has forgotten about COVID. Suppose you vaccinate dialysis patients. What is the seroconversion rate?
So the normal seroconversion rate after 2 doses was around 80 to 90%, but in a dialysis patient that will come down to around 50% of
Transplant?
so COVID post-transplant.
Not COVID, I am telling vaccine.
Vaccination post-transplant. So we avoid live vaccination post-transplant, and if we the seroconversion rate post-transplant of inactivated vaccines are around 50 to 60%.
Okay, you can go and check that also. It depends upon number of vaccines also, after 2, after 3 vaccines. Can you tell us something about, you mentioned indication for kidney biopsy in
Diabetes.
patients. Can you tell us something about non-diabetic kidney? Suppose you do biopsy, how often will you find diabetic nephropathy, diabetic kidney disease? Does it have any implication on treatment prognosis?
Sir, in around when what we see, like mostly 80 to 90% cases are diabetic kidney disease is only.
No, no, I'm
10
asking,
to
are you aware of any biopsy data, diabetic patient kidney biopsy? What does the data show? When you do biopsy, how many, because biopsy will be done only if there is an indication. When you do
Indication.
that, what proportion are you likely to find diabetic nephropathy? What proportion will be non-diabetic kidney disease?
Sir, around 20 to 30% are non-diabetic kidney disease, but majority are diabetic nephropathy.
Okay, you can go and check that. So it is
Depending
30%, right? 30% is going to be diabetic nephropathy, 30% is going to be non-diabetic kidney disease, and 30% is going to be both. Because
Mixture.
patient may have diabetic nephropathy plus IgA nephropathy, IgG, and many things,
Incidentally
right?
diagnosed.
What is the significance? Suppose you have somebody, biopsy showing diabetic nephropathy, somebody is having non-diabetic kidney disease. Who is likely to fare better?
So the non-diabetic kidney diseases can be treated. So that was the indication of doing the
What does the
biopsy.
data show? That's what we think. What does the data show?
So then I'll
You can go
this.
check that. They generate data, according to the data, if you look at the data, people with non-diabetic nephropathy fare worse. Non-diabetic nephropathy, you can go and check that. This patient has a very strong family history of diabetes. So, what sort of diabetes is he having?
Sir, if
Strong
family
history
history.
of diabetes.
If
Does it have any significance?
so yes, 3 generations. If we have positive history in more than equal to 2 successive generations, then he might have a diagnosis of maturity onset diabetes of young, MODY, what we call.
Okay. All right. Time is up, right? Thank you.